All right, let's talk about influenza. So your differential for diagnosis for influenza, you'll have bronchiolitis on there or any other infection due to respiratory viruses, specifically RSV, parainfluenza, rhino, and enterovirus. Bacterial infections, so pneumonia, that's a common thing to have to compare influenza to. And then non-infectious causes of the lower respiratory tract. Predisposing conditions, so you're going to see influenza in the winter months. Patients who are at the highest risk are those less than 5, but especially 2, less than 2 years of age. Patients who have asthma or chronic lung disease, heart disease, liver, renal, blood disorders, metabolic disorders, or neurologic disorders will be at high risk. Physiologically, it's caused by influenza A or B, and this is spread from person-to-person contact with respiratory secretions or contaminated objects and droplets spread. So the manifestations are fever, cough, rhinitis, headache, myalgia, and other symptoms. The patients may have GI complaints as well. This can be pretty hard to diagnose in patients who are younger and can't describe how they're feeling. You can get complications with influenza, otitis media, bacterial pneumonia, and it's important to realize with bacterial pneumonia, they're at higher risk for getting staph and strep infections, specifically MRSA. It can get pretty sick pretty fast, so we need to remember that as well. And then myositis is also a complication that occurred too, and it's usually in the calf region. So to evaluate for the influenza alone, we will do a PCR, which is the gold standard. Antigen testing is done but lacks sensitivity. There's usually not a reason to get a chest x-ray or blood work done unless we're concerned about complications of influenza like a secondary bacterial infection, that kind of thing, because otherwise those studies can just cloud the picture. As far as treatment goes, it's important that everybody gets immunized, especially those who are at high risk for complications from influenza. If high-risk patients come in contact with someone with influenza, you can prophylax them with oseltamivir and zanamivir. In treatment in normal patients, it's not always required. It's said that treatment should begin within 48 hours of onset of symptoms or fever, and this will shorten the course by 1 day, but this is debatable, and it's even debatable if treatment does anything at all. And again, we use oseltamivir, zanamivir, pyramivir as treatment. Patients who should get treated are those who are hospitalized and confirmed with the diagnosis, if they're at risk for increased complications. If the provider feels that they may be able to shorten the duration and that it would be worthwhile, that would also be a reason too. And then it's important with influenza to avoid aspirin because of Ray's syndrome. So let us know if you have any questions. Thank you.